Hello, welcome to my channel. I am Dr. Ju, Arabian radiologist. This is a sonography-radiology training channel. I will present different videos could be benefit for physicians and general population. This is the fifth video about imaging findings in leukemia, mostly about extramedullary manifestation of leukemia in ear, nose, and throat. Extramedullary leukemic infiltration in the paranasal sinuses in nasal cavity and ear is a rather rare event. These entities only were seen as case reports. The first section, paranasal sinus involvement. In a true autopsy survey of leukemia patients found no extramedullary involvement in the paranasal sinuses or nasal cavity. In another study from 273 acute leukemic patients, leukemic cell infiltration was found in the head and neck in 88 patients, but they did not find any sinonasal involvement. Lymphoma of the nasal cavity and sinuses was discussed relatively more common than leukemia. It is difficult to differentiate leukemia from lymphoma by clinical findings and histology, because both diseases may present as solid tumors showing lymphoblast infiltration of the paranasal sinuses or nasal cavity. Examination of the bone marrow is required to confirm the final diagnosis. In addition to a thorough history and physical examination, imaging studies play important roles in the clinical decision-making, especially when the complications of sinusitis are suggested. In comparison with CT, plain films are less specific and sensitive in depicting the extent of the sinus abnormalities. The primary advantage of CT is to depict bone, bone air, and bone soft tissue interfaces. The status of the bony walls of the sinuses is important both in benign sinus disease as well as sinus neoplasms. MRI has become the imaging modality of choice in patients with complication of paranasal inflammatory disease, whether orbital, intracranial, or deep facial spread of an inflammatory process. Now, a case presentation. This axial contrast fat surface T1 image demonstrates right exophthalmos and heterogeneous enhancement of the orbital and periorbital fat. Orbital cellulitis secondary to ethmoid sinusitis was the diagnosis. As to sinonasal tumors, MRI is superior in delineating the tumor from surrounding secretions, which both of them are high signal on T2. Now, another case presentation. This is an olfactory neuroblastoma demonstrated by MRI. In this sagittal T2 image, prior to IV GAD injection, there is poor discrimination between the tumor and retained secretion in the sphenoid and frontal sinuses. After IV GAD injection, enhancement of tumors now allows better discrimination of tumor and retained secretion. Signal from retained secretion does not enhance after gadolinium enhancement. Only 5% of sinus tumors have high T2 signal intensity. Some minor salivary gland tumors, schwannoma, rare hemangiomas, and a small subgroup of inverted papilloma. Unilateral opacification of paranasal sinuses in the CT or MRI, especially in older patients, may be an indication for a neoplasm or mycotic sinusitis, and therefore early histological diagnosis or operative treatment is strongly suggested. Treatment for adult acute lymphocytic leukemia patients in distinct subgroups of these patients is necessary include intensive cyclic systemic chemotherapy, prophylaxis of central nervous system relapse, and bone marrow transplantation. Because extramedullary involvement of the paranasal sinuses and nasal cavity in leukemia is a rare event, there is no consensus on what constitutes the best treatment. As for the central nervous system and testicular relapse, the two most common forms of extramedullary relapse in ALL, local irradiation and chemotherapy, were suggested to obtain prolonged periods of remission. Infections and hemorrhage have been the major life-threatening complications of patients with acute leukemia. Neutropenia and disruption of the normal mucosal barriers of the respiratory and GI tracts are contributing factors to the high frequency of infections in leukemia patients. Sinusitis is common in patients with leukemia and usually occurs when the patient is leukopenic, which in turn is frequently associated with chemotherapy or bone marrow transplantation. Therefore, sinusitis is commonly considered to be due to immune deficiency in leukemia patients. Sinonasal tumors are frequently seen clinically as chronic sinus compliance. They often coexist with chronic inflammatory diseases and can be overshadowed by existent infection clinically. Now, a teaching point. In leukemia patients with symptoms and signs of sinusitis, obstructive causes including malignancy should be considered and evaluated. Another case presentation, a 24-year-old man with ALL, right cheek pain and swelling for 4 days along with right nasal obstruction and purulent rhinorrhea for more than 4 months. 1 week later, he suffered from right periorbital pain and exophthalmos, which progressed rapidly within 2 days. A non-enhanced CT of the paranasal sinuses revealed a right maxillary sinus lesion, erosion of the orbital bone and extension to the right orbit, right nasal wallet, opacification of the right frontal and ethmoid sinuses was also noted. The diagnosis of a second relapse of ALL with infiltration of the right maxillary sinus was confirmed by bone marrow aspiration cytology. With antibiotic therapy and regular local debridement, symptoms of orbital complication completely resolved and purulent rhinorrhea subsided. Hemorrhage of the right eye developed 3 months after the third course of chemotherapy. However, no significant disturbance of vision was noted. Opacification of the right sinuses was still noted on a follow-up CT scan 6 months after surgery, but it did not cause any discomfort to the patient. This coronal CT image 6 months after surgery showed right maxillary and ethmoid sinuses lesion without involvement of the extraocular muscles. Another teaching point about paranasal sinus involvement. Sinonasal involvement in acute lymphocytic leukemia is a rather rare event that must be distinguished from lymphoma. Although immunocompromised patients with ALL have a high risk of infection, sinusitis cannot be regarded strictly as an infectious disease, and a complete evaluation for obstruction should be performed. Surgical debridement is effective in relieving sinus obstruction, treating orbital complication, and obtaining tissue for histopathology. Malignant lymphoma with paranasal sinus involvement. The head and neck region is the second most common site for extranodal lymphomas after GI tract. Non-Hodgkin lymphoma is the second most common malignancy in the sinonasal tract after squamous cell carcinoma. Patients classically present in 6 to 8 decades of the life. The reported male to female ratio is 2 to 1. Diffuse large B-cell lymphoma most commonly arises from the paranasal sinuses. The maxillary sinus is the most common site of involvement, although this type of lymphoma may arise from the nasal cavity. T-cell lymphoma most commonly involves the nasal cavity and shows a predilection for occurrence in Asian and South American populations. B-cell lymphoma has a better prognosis than T-cell lymphoma. CT findings include sinonasal lymphomas frequently show both infiltrative or permeative bony invasion and exhibit varying degrees of regional bone destruction. Non-Hodgkin lymphoma with permeative type tumor invasion typically cross the sinus wall and exhibit remnants of sinus wall as a linear structure within the tumor. In contrast, bony remodeling caused by the lymphoma may also be accompanied by bone sclerosis. This axial CT image shows bone sclerosis with infiltration into the infratemporal fossa and the nasal cavity. There is a sclerosis of the posterior wall of the maxillary sinus and the petrichoid process. Another CT image. In this CT image also there is bony sclerosis in the greater wing of the sphenoid. MRI finding. Non-Hodgkin lymphoma usually show iso-intensity on T1 and slightly hyperintensity on T2. Although the signal intensity of non-Hodgkin lymphoma is non-specific, but the ADC map helps differentiate these tumors from other malignancies. In the maxillary sinus, the ADC values of non-Hodgkin lymphoma were shown to be lower than the squamous cell carcinomas, which reflects a greater cellularity of non-Hodgkin lymphomas. Also, non-Hodgkin lymphoma usually appears as a homogeneous enhanced mass. Necrotic areas within the tumor are occasionally observed in T-cell lymphoma. Now a case presentation of malignant lymphoma. This axial T2 MRI image shows a soft tissue mass slightly hyperintense compared to muscles involving the left ethmoid and cavernous sinuses. Axial T1 image without contrast better demonstrate involvement of the left petricho-palatine fossa and middle cranial fossa. Post-contrast fat-separate axial T1 image reveals intense enhancement of the mass. Other diseases involving the nasal cavity and paranasal sinuses with similar imaging manifestation as lymphoma include Wegener granulomatosis, multiple myeloma or extramedullary plasmacytoma, and coloroma. In the sinonasal region, Rossi-Dorfman disease, that is sinus histiocytosis with massive lymphadenopathy, frequently mimics the imaging appearance of lymphoma with the frequent addition of prominent cervical adenopathy and multifocal extranodal lesions. A case presentation. This is extranodal orbital involvement in Rossi-Dorfman disease. Axial CT image demonstrate abnormal heterogeneously enhancing orbital soft tissues, producing marked bilateral exophthalmos and bowing of the right optic nerve. Coronal CT image from the same examination reveals involvement of the ethmoid and maxillary sinuses and the nasal cavity, with prominent orbital floor hyperostosis and demineralization of the turbinates. Another section is middle ear involvement. Since this form of recurrent leukemia of the middle ear is rare and the clinical manifestation can mimic acute otitis media and B-cell palsy, it may not be readily recognized. Case presentation presented at 2012, a 4-year-old boy with a history of pre-B-cell acute lymphocytic leukemia, status post-chemotherapy, presented with left-sided Bell palsy. This coronal plane of temporal bones and axial plane of the left temporal bone show an infiltrating soft tissue mass involving the left middle ear extending into the proximal portion of the external auditory canal and mastoid ear cells. These changes were mimicking an inflammatory process until a biopsy proved them to be a leukemic infiltrate. Before 1990, physicians relied on surgical excision or autopsy to diagnose leukemia of the middle ear. In 1990, considered shifting to histologic and cytologic evaluation of the tympanic exudate to launch the diagnosis of leukemic involvement of the middle ear successfully. External ear canal skin lesions, red or thick tympanic membrane, middle ear effusions and otitis media, hearing loss, and mastoiditis have been linked to underlying leukemia infiltrating the temporal bone. A case presentation presented at 2021, an 8-year-old male with acute myelocytic leukemia with severe ear pain, persistent ear discharge, and hearing loss with left facial paralysis. Axial section of temporal bone show soft tissue surrounding ossicular structure in mastoid cells and middle ear cavity on left ear. This T1 coronal section postcard and T2 image shows a contrast enhancing lesion. Now, teaching point about middle ear involvement. Leukemic temporal bone relapse should be suspected in acute myelocytic leukemia patient with symptoms of osteomastoiditis and facial palsy. Further investigations, including radiological examination, surgery, and biopsy for avoiding misdiagnosis and delay in treatment, are needed. Another section is throat involvement. Current literature regarding the presentation of CLL of the head and neck is very limited. Although lymphomas often present in Waldeyer's ring of the pharynx, involvement of the oral cavity, larynx, and hypopharynx is exceedingly uncommon. The most common oral manifestation in leukemia in order of frequency include gingival hemorrhage, mucosal ulcers, infections, and gingival hyperplasia in tooth-bearing areas. Tooth loosening can occur from loss of the periodontal membrane. Leukemic infiltration of the tonsils and salivatory glands can lead to their enlargement. Less commonly, as a result of leukemic infiltrates, multiple localized tumor-like growths can occur in the gingiva. The oral manifestation of the chronic leukemias are less common than acute lymphocytic leukemia. The oral manifestation associated with CLL are less common of all the chronic leukemias. Palatal enlargement secondary to leukemic infiltration is rare, only as case report up to counting the fingers of one hand. The palatal swelling usually present as a painless, soft to firm lobular mass with an overlying intact mucosa and incomplete midline furrow. This is the first case of palatal enlargement secondary to leukemic infiltration present at 1960, which shows symmetrical bilateral enlargement of the palate due to infiltration by leukemic cells. The relatively symmetric configuration of this process makes other palatal masses such as squamous carcinoma and minor salivary gland tumors quite unlikely. Benign follicular lymphoid hyperplasia or FLH affecting the oral surface of the hard palate is morphologically identical and therefore confusing in appearance and presentation. FLH in this location may present as a slowly growing, smoothly lobulated submucosal mass. Like this case, intraoral appearance of the mass lesion overlying by normal mucosa on the maxillary posterior side. This axial CT image shows a clear, circumscribed solid mass between the lateral aspect of the posterior maxilla and the anterior region of the masseter muscle. This is MRI of the same image, shows homogeneously enhanced signal intensity on T1 image after gadolinium injection, high signal intensity on short T1 inversion recovery image. Because isolated palatal enlargement can be the presenting feature of both CLL and FLH, and because FLH can recur after excision, it is important to distinguish these entities through pathologic examination. These patients with either CLL or FLH palatal disease are typically asymptomatic for the palatal enlargement, except for ill-fitting upper dentures. Other diagnostic considerations should include lymphomas of all grades, whether primary, nodal, or extranodal. Even though palatal involvement by lymphomas can present as soft, non-tender bilateral palatal swelling, in many cases the palatal disease is unilateral, hard, painful, and accompanied by bone destruction, like this case. The final diagnostic differentiation between CLL, FLH, and the lymphomas can only be accomplished by pathologic examination. Also, a variety of other lesions such as minor salivary gland neoplasms, turus palatinus, and infections and abscesses can affect the hard palate. They are easily distinguished clinically and histologically from CLL. This is the case of turus palatinus, which is a harmless, painless bony growth located on the roof of the mouth. The mass appears in the middle of the hard palate and can vary in size and shape. About 20 to 30% of the population has turus palatinus. It occurs most frequently in women and those of Asian descent. Now a case presentation. A 62-year-old man presented with a 3-week history of bilateral neck fullness and a mass in his palate. He had no pertinent prior medical history. Physical examination showed bilateral multipenile tendal lymphadenopathy and a large firm palatal mass with a midline ridge. Blood work revealed leukocytosis, and she was diagnosed as having chronic lymphocytic leukemia. MR imaging showed smoothly lobulated soft tissue masses confined to the oral surface of the hard palate on either side of the midline. This axial T1 image shows nodular soft tissue masses of low to intermediate signal intensity along the oral surface at the level of hard palate. This axial T2 image shows the masses have an intermediate signal intensity that is higher than in T1. The smoothly lobulated nature of the masses with a midline cleft can be well appreciated. This postgad T1 shows uniform enhancement of the masses confined to the oral surface of the hard palate with an incomplete midline furrow. Now, teaching point about throat involvement. Palatal involvement in CLL is rare and has only been reported as a few case reports. When smoothly lobulated homogeneous masses are identified on the oral surface of the hard palate, especially in a patient who had a diffuse lymphadenopathy, the diagnosis of CLL should be considered. And the last section is upper airway obstruction. Upper airway obstruction resulting from CLL is even more uncommon. Although rare, airway obstruction is more often the result of mass effects from hilar and mediastinal adenopathy. More common malignant causes of upper airway obstruction include locally advanced lung cancer as well as metastasis from thyroid, skin, head and neck, or breast cancer. Richter transformation can occur in 3 to 10% of patients with CLL. Underlying infections have also been implicated in triggering this transformation. Also, it is still debated. It is theorized that the Epstein-Barr virus has a role in Richter transformation through direct oncogenic stimulation or through mitogenic and activating signals within the microenvironment. Rapid clinical deterioration is often a hallmark of Richter transformation. The usual presentation of this aggressive transformation often includes increasing lymphocytosis, progressive cytopenias, elevated LDH, diffuse bulky lymphadenopathy, but sometimes the only presenting sign is rapid respiratory decline. Infections are indeed the leading cause of death in patients with CLL and can account for up to 60% of disease-related mortality. Now, case presentation. A 62-year-old woman with CLL was initially diagnosed in 2007. She underwent close observation for several years. However, in 2011, she presented to the emergency department for complaints of feeling a globus sensation over the span of 48 hours. This symptom was associated with dysphagia, diffuse myalgia, high-grade fevers, and shortness of breath. This contrast-enhanced CT shows a heterogeneously enhancing mass involving the palatal tonsil, causing severe narrowing of the hypopharynx. Given the patient's initial presentation with rapid deterioration resulting in respiratory failure, Richter transformation was considered. This CT scan was taken after 2 cycles of chemotherapy, shows nearly complete resolution of the mass. Now, teaching points. An unusual presentation of CLL could be airway obstruction. Prompt recognition is required to institute early intervention. Initial biopsy findings may show a possible bacterial infection in a patient with known CLL. However, a superimposed bacterial infection may have complicated the clinical picture. Nevertheless, cases of infection mimicking CLL progression have been described, and accurate identification of the underlying etiology is essential in order to make appropriate treatment decisions. The patient can respond very well after completing the cycles of chemotherapy. And finally, this is the references I used for these presentations. If you like this video, please subscribe this channel. If you would like to get notification for the next videos, please press the small bell. If you have any question or video suggestion, please write in the comments. Thank you for your attention.